feeling and understanding. But it just talks more about that in there. The pain and symptom management, I think next month we have for the nurses a more in-depth pain management and symptom management. It just talks briefly in here. Every patient has the right to have their pain controlled. It's just so important that we're able to do that. And always to keep in mind, maybe that patient is at the desk asking for a pain medication and you think, you just had it 3 hours ago. Well, everybody's metabolism is different, so pain medications in each person will work faster or not as quickly they would go through the system. So always keeping in mind and believing what that patient tells you when they talk about being in pain and being able to help with that. Using your PRNs. The more you use your PRNs, the more we know how to convert to long-acting medications. So you don't have to give it as often. So all those things with pain, again, you can't do an x-ray, you can't do a blood pressure and say this is what somebody's pain level is. You have to trust what they're telling you and to look at all the other factors. If our patient can't talk, are you looking at the behaviors? Are you looking at, oh, we go to get them dressed and every time we go to put their arm in, they're swinging at me. Well, do they have some osteoarthritis or some pain in that shoulder? So when you're trying to put that sleeve on, that it hurts, and they don't know how else to tell you that it hurts. So looking at the behaviors if they're not able to verbalize how the pain is. And then of course there's different types of pain. There's acute pain, chronic pain, and then malignant pain is a combination of the two. Most of the hospice patients are for more chronic pain. Some are a combination with new things, tumors, new things popping up where they run into that acute pain. The biggest thing to remember is that acute pain, it's something new, it's something usually that doesn't last long. It's something new that's happening, so you're anxious. Oh my God, I'm going to move and it's going to hurt. And so there's a lot more anxiety. The chronic pain, you get more of the depression and that type of stuff with it, and not so much the anxiety. So that's kind of a big differentiator when you think of treating it. And then always what type of pain is it. Misconceptions, it just talks about a sleeping patient doesn't have pain. Many times I've seen, when they're using like a shorter acting every 4 hours to give a pain med, that, oh, they're sleeping so we're not going to wake them. Well, by the time they wake up, they're in such severe pain that it takes you another 12 hours to get that patient comfortable again. And think about if that was you, is that how you want your pain treated? I wouldn't. I'd want to make sure that we can get something. So always think, if you're doing that every 4 hour med, how often are we doing that? And can we get it to a medication that's going to last 12 hours or 8 hours or something, so we're not having to wake them, but to use that short acting to find out. And then it just talks about the skilled nursing facility implications and benefits. It just talks about the proposed nursing facility companion rule that's proposed to come into your regulations, or the COPs, which is conditions of participation. And it's basically the same thing. A manner in which the long-term care facility may furnish hospice services to their residents. A minimum content of the written agreement between the long-term care and the hospice. So we do contracts with all the nursing homes that we work with. We have contracts saying how is this going to work together, how's the room and board pass through, what happens with our services coming in. So all that is already written and in place. Participation and coordination of the long-term care facility in care planning and delivering that care. Again, that care plan that we do together. And then information the long-term care facility must obtain from hospice. So again, sharing our notes, sharing what we're finding at our visits at all times. And then the surveyors, the nursing home, of course, when they go to pull their sample patients, it's common that they're going to pull if you've got high count of wounds. They're going to pull if there's a hospice patient, most likely. So as soon as those surveyors come in and there may be a question, let us know, because we will gladly come out here. We can help double check the charts. We can help answer any questions the surveyors would have, anything like that. So just call and let us know that they're here. And then our staff know as they come in the building too if there's going to be surveyors there and if they're going to have questions. The benefits to hospice, to the residents and families, again, just having that additional support for you guys and for those families and clients. That professional staff available 24 hours, 7 days a week to help support your staff. The psychosocial, spiritual, the payment of items to help with that terminal condition, again, can be very helpful for families. Residents, personal physician, we collaborate with them, they continue with their personal physicians. and then our bereavement that's provided for that 13 months after. The interdisciplinary teamwork, just like here you guys do an interdisciplinary team with all the different team members, same thing with us. Now we just have a bigger team because it's us together. The consult for pain and symptoms, and then extensive staff experience and training with that pain, symptoms, grief, loss, all of that. And then the benefits, again, it talks more about the interdisciplinary team, that palliative care, the consult support, and repetition there. Any questions about some of your things that come? One of the forms I did give you that does look like, here's just a copy of this. This simply just tells you what the new regulations are on one side and what Heartland's done to meet those. Most of the things you see there, Heartland's already been doing, just as best practices, so there's not a lot of change in the services that you would actually be getting through us. So this is just kind of a snapshot of what that is, of those same areas. The other piece that I will leave here with you guys, and have somebody that will have people in the nurse's station or whereabouts, but it's the hospice facility manual, and it goes into a little bit more in depth of the stuff we just talked about. It's very nice because it goes through the overview of services. It talks about the admission guidelines and levels of care, so if you've ever got questions, that book is right here for you. It talks about the hospice responsibility and what the facility responsibility is. So it lays that all out on here. It talks about documentation, how the documentation with the regulations and stuff, how we would find those. There's a section called Assisting the Dying Person, and this is a really good section if you ever have a little bit of time to review, or if you've got newer staff that haven't worked with death and dying, to look over. It really kind of addresses how to talk to the families, how to work with people that are dying, how to communicate with them, things you're going to see as that patient's dying. So it is a very good section. It's very well written on how to work with that. Influences on perceptions of death and dying. So it does go through quite a bit. So it's a very good spot. In the back, there's just some addendums. There's one quick sheet that symptom control measures is in here. There is There is an integrated care plan kind of guidebook. It goes through the main quality indicators that you guys have to have. And so if you talk about behavioral and emotional, one of the things, if you know that patient's going to decline their hospice, you're anticipating declines in them, you want a care plan that you're going to anticipate the decline. You're not going to care plan that we're going to have to gain all this weight. When you know what that disease process, they're not going to be in that weight. You want to be realistic. Here gives you kind of what the indicators, kind of what surveyors may look for, kind of some palliative care goals that you would have in some interventions that would meet that palliative care piece. So it goes through that very nicely. And then it also goes through the hospice toolbox in here, and some of the unit managers have them on a little book instead, but it does go through here. And we talk about eligibility, and that's part of what's on there. And so you're wondering, this patient with heart, they don't want anything more. They want comfort cares. They want all of this. What other kinds of things would we look at for that? So in here, it lays out heart disease and what it is. That blue sheet I gave you is a quick check. That this is a little more in depth than what that is, but it just talks about, you know, their ejection fraction. What is that? Are they short of breath at rest? Those kinds of things. You know, is that patient having edema in there? They really can't handle anymore of the diuretics. So there's things going on that way. You're sitting there having a conversation with them, and they say one sentence, and it takes them, you know, another 30 seconds to catch their breath when you're talking with them. Those are those patients that are so short of breath, or, you know, just with transferring, they get that chest heaviness sometimes, or if they walk 10, 15 feet, they're short of breath and having that chest heaviness. So some of those things it talks about goes through pulmonary disease in here. What is their O2 stats running without oxygen or with oxygen? Are they where they're oxygen dependent? Does that patient keep getting repeated infections? They're always getting another bronchitis or another pneumonia. They end up in the hospital frequently because of that. They're just not recovering. They maybe have some of that barreled chest going on where it's getting They're using all those muscles to try to catch their breath and with their breathing. They're probably on nebulizers or maxed out inhalers. So it talks about that. It goes on to Alzheimer's disease. Alzheimer's disease, really looking at that patient who probably can't walk, especially independently anymore, maybe with 2 assists and telling them to move their feet, they can. They're getting aspiration pneumonias, they're getting kidney infections, they're getting repeated infections, they're having trouble with their swallowing. They need to be fed, but you got to remind them to chew their food or to swallow their food, different things like that. That cognition isn't there anymore. They're usually losing weight because of the swallowing problems or just not being able to know to swallow and chew or just they don't want to eat anymore. You know, they're clamping their mouth shut, they're swinging out, they won't eat anymore. Maybe they're losing weight despite the supplements you started. It talks about renal disease in here, so those kidneys are failing. Maybe they're coming off dialysis, and so they would qualify at that point. Maybe they look at dialysis, but really they don't want that for end of life. You know, it's really not going to do much for them because maybe they have multiple other systems that are failing, so they may fall in there. Liver disease, it talks about that in here. You know, they're having the ascites, they're getting that jaundice color, that yellowish mustard color sometimes is showing already. They're having variceal bleeding, muscle wasting, they're needing more help with their ADLs, all of those things. Stroke, coma patients, you know, that new stroke patient who really shouldn't be eating because they are such a high risk for aspiration. That family doesn't want the tube feeding, patient doesn't want it. He doesn't want to do the specialty diet, the thickened liquids, you know, those kinds of things, and he's getting repeated infections, losing weight, those types of things that may be happening. Or maybe they just didn't ever wake up after their stroke, so they're in that coma state. So that might be something. ALS, we've actually worked with quite a few ALS patients. And our medical director, Dr. Lally, is working with the ALS Society, and they've been doing many presentations, and they're going to do a presentation for the Hospice Minnesota conference that's coming up. So he's really taken kind of a specialty in looking at palliative care with ALS patients. I don't know, do you guys have ALS patient out here at all now? Those patients are usually younger. There's a lot of fear. I mean, when you can't do things for yourself, your mind's there, but you know, you're afraid that the breathing is getting more difficult. Your mind's there and you know what's going on, but you can't move your hands. You can't do those things. It's scary. So those patients really need that extra support with them. We had one patient who just had so much pain and rigidity with his muscles. That pain control was a big issue, working with them and finding what meds work, what ones didn't with that type of muscle and neuro involvement. HIV is listed in here. ADL changes and just treatment decisions are in here also, and I did put those on your handout a little bit. I'm just looking at, have they decided to be a DNR now? Are they not wanting to go back to the hospital? Is it a patient who is maybe losing weight, their heart's kind of failing, but you're not meeting that criteria for the heart yet? Their lungs are pretty bad, there's just multiple things happening, but they don't fit into anything. That's okay. We can use like a debility diagnosis. Or it's that patient who's dying of that broken heart, who's losing weight, really doesn't want to do much, withdrawn, not coming out for their favorite activities. They may fall into more of a failure to thrive. So those aren't in here, but those are always options that we can look at too. And then of course our cancer patients. So I will leave this for you guys here to be able to look at that or to review it in the meantime. And if you need a second one, just to let me know at that point. Any questions? Okay, I did leave you guys with a eval. If you guys would fill that out, that would be great. I did leave CEU certificates in back also. As patients come in, hopefully we have brochures that talk about hospice. Our new brochures really go through, if a patient has questions, it really outlines what hospice is here for your family. So if they come on the weekend, saying, I heard something about this, you can always really direct them to the brochure. It talks about the comfort, the dignity, what does it mean, how do we provide services. So our new brochures lay out who's going to come out and see them. So a lot of that information is in there very well. Talks about how we can help you, those types of things. So even if they wouldn't go at Heartland, this still lays out what the hospice benefit is for those patients. So there are those here. And of course, we do home care and infusion too if patients would be going home. Thank you guys, and again, I apologize for being late. Thank you for giving me a little extra time to stay here today, so thank you.